You are live now, sir.
Good evening, everyone. Welcome to our fifth episode of DOS Corneal Surgery Learning Courses. And just to give you a brief intro for the new members who have joined this time, this is a course which aims at teaching you the basic steps of any corneal procedure, mostly through videos. And today we are really happy to have one of the teacher for DMEC. Dr. Basak sir has taught us DMEC. And in fact, the first DMEC hands-on training at RP Center was by Sir only. Then he came and he taught us how to do DMEC. And he must have done this all over the country and even internationally also. Along with Sir, we have a few experts here. Professor Namta Sharma, she will be joining soon. Again, she is heading one cornea unit here. You know, ma'am, quite well. She is also a great DMEC surgeon. We have Dr. K.V. Satyamurthy, sir, from Karnataka, and sir is in joint director in MM Joshi Eye Hospital. You know, very good cornea surgeon. And whenever DOS invites sir, he's always there to be with us. Thank you so much, sir, for that. We have Dr. Hitendra Ahuja, sir. He runs a big cornea center at Delhi, and again a very good corneal surgeon, and he has a lot of interest in cornea. Dr. Geeta Behra, she is an additional professor at JIPMER, Puducherry, again a cornea person, and she will be joining us soon. And yes, ma'am is there with us. So, along with that, our president, Dr. Rajesh Sinha, he will be joining soon. And yeah, little bit about Samar Basak, sir. I think you all know, sir. He doesn't need an introduction. But the best part I have highlighted in red, which is very relevant to today's program, he's obsessed with DMEC. That is the sentence I think you all should remember. So he's the founder, director, and head of Cornea and Eye Bank Services, Disa Eye Hospital. And we all know, sir started from scratch. Now there are 19 branches and doing excellent job in especially cornea and all the ophthalmology practices in eastern part of India. He was the past president of AIOS, past president of EBAI, as well as Cornea Society of India. He has 10 awards from AIOS, including the prestigious P. Siva Reddy International Award in 2022. Studies are RPC alumni, and he has given oration, LP Agar oration, Professor IS Jain Award, and Madan Mohan orations. He has received the Senior Achievement Award from AO, American Academy of Ophthalmology, in 2015. He has won Best of Show Video, which is a very prestigious award all about innovation, six times at AO, and Best Paper Cornea in AO 2009 and 20, and Best Video Awards at ESCRS and ASCRS in 2025. So he has nine books, and we all know Sir's popular book Nima, and I hope you all have read this in your MBBS career, and 59 papers in peer-reviewed journals. Surgical interest, he's a very high volume cataract as well as cornea surgeon. And he's doing 200 with DMEX per year, and which is a staggering number. And he has performed more than 1600 DMEC in a short span of 9 years. And as I said, he has trained all over India as well as outside India, DMEC to people who are interested in corneal surgeries. And his hobby, ophthalmophilately, I think we must have received in our email. He used to send us, and I think Sarah stopped or still sending stamps on ophthalmology. And that we used to enjoy a lot. And with this, I'll invite Sir to start his lecture. Welcome, sir.
Thank you, Praful, for your kind words and nice introduction. And just I am sharing my slides.
In the meantime, sir, save the slides. I just want to tell you our president, Dr. Rajesh Sinha, sir, has joined. Sir, would you like to say a few words? And another thing is, all my cornea SR, they are very eager to learn from today's lecture. So they have also joined. Welcome you all. And Rajesh, sir, would you like to say something? Just few words. I think, sir, there is some issues. Yes, sir, we can proceed with the lecture.
So thank you once again. So today is this master class or lecture is a very nice, innovative introduction by the DOS, and this is what I have heard that you have going one by one in all aspect of keratoplasty surgery. So I'll be talking on DMEC, the learning the basics. I do not have any financial interest to disclose. So if you see these two pictures from the same patient, right eye I had done dissect.
There's some audio issue. Is it there?
Any problem?
No, can't see this thing, sir, your presentation.
Oh, you
We are
cannot
seeing you on.
Okay, let me
Rajesh
share
sir,
it.
there is a delay in your audio.
Okay, I'll share it again.
Okay.
Sir, meanwhile,
There was some audio issue in my laptop.
Hello, Dr. Rajesh.
Yeah, hello.
Right.
There is something wrong.
Mine is also something wrong. Can cross it. Okay, let me check again. No.
Is audio okay with everyone?
Yeah,
yes,
fine,
sir,
sir.
now we can hear you clearly.
Can you see my slides now?
Yes, sir, now we can
Yeah,
see.
yeah, right.
Okay. Thank you once again. So I do not have any financial interest to disclose. So if you see these two pictures from the same patient, one is DSEC triple, another is DMEC triple, and you can see the difference between two eyes. One eye patient is highly satisfying with 6/6 vision. Cell count, we forget about the cell count at this point. And both the eyes are doing well over a period of now almost 10 years. It is not. So I call it newness of small differences. So DSEC is a very good option. Only difference is 80 to 150 micron more, but not anatomically perfect, and also the visually perfection is not there. So a lot of aberrations are there, and patient may not get 6/6 vision. But DMEC, if you see that, it is perfectly anatomical. So we are changing 14 micron versus 14 micron, and higher chances of gaining 20/20 vision, and there will be minimal or no optical aberrations. So if you see the data from US, they have a very nice data preserved, and every year they update it. So if you see the EK data, every year they are growing. But if you see the DMEC data, in the last 7-8 years, they have jumped tremendously from 29% to 52% of all EKs. And if you see the 2024 figure, DMEC is their highest number of keratoplasty in domestic US of US. Domestic uses like DMEC is 35%, DSEC is 31%, and PK is 27%. So these are the two landmarks which are very important for any corneal surgeon. One is 2011-12, where DSEC surpasses PK, and in 22-23, DMEC surpasses DSEC. So this, because of they are different, they use as prepared tissue, eye bank prepared tissue. That is why, and their supply is more, they have more indication of DMEC than ours. And that's why they are growing in a tremendous way in DMEC surgery. So the first thing is this was a question from one of the audience previously posted, that what is the indication and case selection. So if you see that indication of case selection in all DSEC, DSAK, DMEC are all for endothelial, any kind of endothelial dysfunction. In our country, first indication is pseudophakic corneal edema. And if you get a good pseudophakia with normal people, IOL in the back, that is always the best option for DMEC. But if you get sulcus fixation IOL, there might be problem in centration and AR issue. So it is advised to dilate the pupil each and every case before surgery and so the IOL status. If you get an advanced or long-standing PK with you cannot visualize much, so you see the ASOCT, there is thick hypertrophied epithelium. You need to see the status and then you may go for two-stage surgery because you have to see the potential vision of this patient before taking it for the surgery. So you remove the epithelium, put a bandage contact lens, then dilate the pupil and see the lens status and even the macula condition. And then later on, you take this patient for DMEC or DSEC, anything. So the results will be more towards your perfection of vision. So you can tell the patient what is the potential of the eye and also the same thing. PBK following TAS, it is little bit a problem for DMEC because there is more bleeding occur during the inferior PI. If you avoid inferior PI, that is good. More pigment dispersion during tapping and fibrin thread formation. It may entangle with the DMEC graft and sometimes you cannot open the graft. So I had in 2 occasions, in 3 occasions it has happened. So that those graft actually lost and we have converted to in DSEC. So TAS cases you have to be think very cautiously. Then with anterior chamber IOL, yes, you can do it, but you take the history, how long the patient is doing well. If it is more than 10 years he is doing, that means another 10, 12 years will be going with a endothelial keratoplasty. The anterior chamber should be good with less IOL mobility and pupil should be central in these cases because you need to put the AR might escape posteriorly, then there will be big trouble. And also, you may also remember that this had a higher endothelial cell loss than a posterior chamber IOL. IOL exchange with posterior iris fixated or SFIL with DMEC in the same sitting or sequentially you can think of. Consider the patient age and also the patient comorbid condition, physical comorbidity. Then you can take 2 surgeries or you can go single way and you can give the DMEC or DSEC at the same sitting and take VR surgeon's help if necessary. So these are the cases where we have done and the patient's doing good for 2 years post-op and nothing, there was no problem. Then the second indication is Fuchs endothelial corneal dystrophy and FECD. We see a large number of FECD in this part of the country and you see that the variety of FECD cases, we see early FECD to moderate to severe FECD with epithelial hypertrophy. Sometimes it is almost all of the cases there are cataract and in these cases you need to do DMEC triple. So if the patients present fast and very early stage with malic cornea, these are the very good ideal cases and you can have a very good vision even on day 7, patient can have 6/6 vision. 2 important points when you think as a phaco is considered as a primary surgery, like with the patients with early Fuchs and cataract, you always counsel the patient and give a guarded visual prognosis that EK may be required in any form later on and I will power target, keep it for 0.75 myopic for DMEC, DSEC 1 to 1.5 depending upon which tissue you are with. But if only DMEC is considered as a primary surgery, yes, we have to do in certain cases. Those are younger than 40 years of age. But above 40 years, we always prefer to a combined surgery where patients are in the moving in the presbyopic age, so we can combine this surgery so that later on there will not be requiring any cataract surgery. This is a good indication, like nowadays was Proful was saying that post-disc failed graft. So post-disc it is not difficult. It is same like our disc. You just have to remove that disc lenticle very carefully. You have to score again. Otherwise, there may be iris touching, or there may be iridodialysis during stripping of this disc graft. So you have to be very careful, and then you consider for DMAC surgery as you learn. Here you can do a PI, or PI is done earlier, so there is no matter. Then this is post PK fail graft. Here there are so many issues are there. The graft size, of previous graft size is very important, and vision prior to fail graft. Like if it is a very high cylinder fail graft and you are again doing DMAC, probably is not wise. So in those cases, it is to do a repeat PK. And if there is any pairs and there is any crystalline status, you have to consider, and how you can manage that crystalline lens. This is also important. So it is also important to do a 4-quadrant ASOCT in different zones to see the posterior junction of host graft junction, to see whether there is a huge gap in the posterior host graft junction. I mean, there is ledge formation, they are waist shaped, and those cases it is difficult to have the centration of the graft, and in those cases you have to take a smaller graft. And again, smaller graft means 6.5 millimeter graft you have to choose. Here the only thing is donor detachments is more. This is from my practical experience, more primary and late graft failure. This is also true. And also we have seen over a period of longer period, the graft failure survival is also less. On the other hand, if you take a post-therapeutic fail graft, it is better to do, because the grafts are always large graft. It is always 10.5 millimeter graft. So you can take pretty well the 8 millimeter graft, and the DMAC is very ideal in this situation. If the anterior chamber dynamics is all right, anatomy is all right, you can go for DMAC surgery. Then post-trap, tube, shunt, these are difficult issue because they are tend to escape. You have to give air very slowly, very slowly. Sometimes you need to block the tube with little bit of heavy viscoelastic, then you have to inject air. But sometimes if the tube length is larger, you have to trim the tube, because there is always a chance of tube touch and it is very difficult to make centration. I have done few of the cases, and with the trimming, again the graft dislocation or graft detachment is higher in this, because of you cannot maintain sometimes the proper anterior chamber pressure, air tamponade inside the anterior chamber. Other indication like PPCD, posterior polymorphous corneal dystrophy, shade is a good option if they present early, but if they present less, where you cannot see much, there the shade you better to go for DSEK surgery. Then eye syndrome, I have a good number of eye syndrome. Eye syndrome, you have to be very careful. And there is a chance of bleeding during pass release, and you have to be careful of releasing. You have to take a call whether you will go for, depending upon the amount of pass you have to do it. Then I have a group of cases I have already presented, published, that post HSV endotheliitis, irreversible corneal edema, where you can do it, and it is almost same, only you have to cover them with a lot of steroids and others, as well as antiviral, like I prefer valacyclovir in this, and post-traumatic sometimes you have. So these are all miscellaneous indication. like this is HSB endotheliitis and DMEC, and the patient is doing good over a period of almost 8 years. And she is actually one-eyed and doing good. This is eye syndrome. So eye syndrome, Chandler, we have seen it is easier to do rather than, and Chandler-Cogan we do not see much, but essential iris atrophy because of multiple holes, polychoria, the air retention sometimes is a problem. But if you combined with a cataract, then it is a better option. Sometimes this patient presents in early age. I do cataract even in early age because you have a lot of space and IOL as a support to prevent air escape. So graft usually lower, smaller size, 7 to 7.5 millimeter. Contraindication for the beginners is vitreous in the anterior chamber, aphakic cases, or if you have a bad extensive pass as in eye syndrome, then you have a decentered anterior chamber IOL with large PI, or if you have otherwise there is a poor visibility. So if you have a very poor visibility, you should not attempt DMEC because otherwise your tissue will be lost, your manipulation will be more. Even if you are successful, your graft will be failing very early. So these are some of the, not a candidate like central scarring with vascularization, total aniridia with aphakia. And if you see that this is just history of IOL surgery 5 months and the patient has a CCT of 1500 micron. So you cannot do anything. Even dissect is not possible in these cases. So otherwise, as I said, shade more than 100 micron thickness, you should not attempt a DMEC. Rather, you could give a chance of dissect in these cases. So indication-wise, in Western world, FECD is the primary indication, 80%. 60 to 65% is the in different series also. And the PBK or corneal edema is like 15 to 20%. Others are like 10 to 15%. Early shade PPCD are very less. But in my series, in India, our cheap indication, most of the publication says that 70 to 80% is post cataract, PBK or APCD 10 to 20%, miscellaneous is 5 to 10%. But in my series, I have already published in the 1,000 cases. In PBK is like 42%. Our FECD series is highest in the country is around 36%. Now it is 39%. Only in Bengali patient it is the population is higher. So ideal case like pseudophakic corneal edema is with PBK is the more common, good visibility, good anterior chamber anatomy, round normal people, IOL in the back. And always, as I said, always dilate the people before, during workup to see the status of the lens. FECD cataract, if you are a primary surgeon, do it. Not a so difficult cataract. And you can, if there is adequate dilatation, you can combine. These are the very, very early initial cases. These are the two types of indication where you should start with DMEC. There should not be any problem. Some workup or pre-operative evaluation, I always say that I always maintain this chart, like all the patients have this is a long chart about the, because when you try to publish the data, these data points are very important. So you see that all the data is there, that, and I can take piece by piece and then I can publish paper in various, already I have published several papers on many issues like diagnosis of the other eye is also important. It is good gut data or evidence of Fuchs or normal as in eye syndrome. In most of the cases, it is unilateral. Then prior corneal surgery, as I said, those are very important. And these are to segregate them. When you have a large data, you can segregate them and take the one by one group, and individually you can publish your results. Similarly, with pseudophaky, keep the PI. And I also said that yak capsulotomy, you must say that yak capsulotomy size, I had problem in 2 cases where I have seen a large ERPI was done almost 80% of the size of the lens optics, and when I put the AR went behind. So it is a problem. Then tackling that AR and taking into anterior chamber again is a big problem. So you must check the size of the opening is very vitreous in the AC. Sometimes it is very difficult to assess preoperatively during the operation. Put a little bit of air bubble inside the AC and take two forceps in your hand. Move the eyeball from one side to another, and if you see that the air bubble is freely mobile, small air bubble, then there is no vitreous. If air bubble is not moving freely, that means there must be something wrong in the anterior chamber. Then workup USG B scan is also important. Axial length for biometry. Other eye also important. Very difficult to calculate biometry for DMEC triple in some of the moderate to advanced cases. Anti-segment photography for your own documentation and publication. Anti-segment OCT different type is important. Anesthetist clearance. Macular opacity possible because there are a lot of published paper. You see that because we surprises to you have done nice surgery, patient 4+ clarity and the patient is not. Then you take the macular OCT, there will be huge CME, especially in PBK cases. So any PBK cases, if you have a chance of clarity is sufficient, you take macular OCT prior to operation and ask the patient to and counsel the patient, yes, intravitreal injection of STK will be required in these cases also. So phakic corneal edema, so cataract surgery or no cataract surgery, as a rule, as I said, that above 40 years of planned DMEC IOL. And if it is less, cataract is faster. I have done few and surgical manipulation, you know that sometimes it is more. Air-induced trauma, steroid is there. Then if you take the DMEC triple, what is the IOL of choice? IOL now, cataract surgery preferred by phaco, but in advanced cases we have also had video in American Academy accepted that manual SICS and DMEC, and we have to do in certain cases. Then IOL selection is hydrophobic acrylic is the best choice. So Acrysop single piece IOL or Technis 1 IOL. In primary cases, no to yellow IOL only. There is other eye is yellow. No to multifocal IOL and toric IOL. I have had few patients. If the astigmatism is like an early edema, astigmatism is more than 2 diopter, then you may think of giving a toric IOL. And target I have said already 0.5 to 0.75 myopic. Specular microscopy of the other eye is very important. It is for pseudophakic patient. And to get the other eye, sometimes you will see that undiagnosed Fuchs. And to give confidence to the patient, like if the normal reading, you tell that the other eye is normal, so you do not have problem after cataract surgery. But to guard your colleague, if you face you see Fuchs dystrophy in the other eye, you say that it will happen also in my hand, so nothing wrong with the surgeon. So I always guard my cataract colleague if I see the Fuchs dystrophy in the other eye. So up to this indication, so do you have any question or anything? Praful? Any question at this point? Because I will be shifting now the second part, DMEC graft preparation. Any question, anything, or I continue?
Sir, you please continue because our audience is in a different platform.
Oh,
So the
okay.
team will
Okay.
compile and share it with us.
Okay. So next this is an important part, the DMEC donor preparation. This is very important because this is the first hurdle for any DMEC surgeon. So what is the ideal donor tissue? MK medium, Cornisol, Optisol, GS, anything. I prefer anything. Donor age must be critical, like 55 to 75 years. So higher the age, better chance of yield from a non-diabetic donor. Endothelial cell density must be 2500 with a good morphology. Give adequate thawing time, about an hour in the operation theater, and in first few cases give some standby optical quality tissue. You have a source. So these are very important, which should be your ideal donor tissue. So when you ask for a tissue, you mention these are my criteria. They fulfill this criteria, this would be like nothing. You will be almost 100% successful with yielding a donor preparation. And they see that US surgeon, 80% of them used iBank prepared tissue. They always say that they are privileged, they are spoiled. In fact, the EK surgery US start in iBank. They use pre-strip, pre-stamp, pre-stent, pre-punched and preloaded PP DMEC graft. But India, most of the DMEC surgeons have prepared their DMEC graft during the surgery. Recently, 2 iBanks, they are supplying pre-peel tissue. And donor damage during, from literature, it is between 0.7 to 4.3%. So it is not that much. That's why I say that you must keep standby for first few cases. If you do 10 cases, 15 cases, then you are easy. There will be least chance of donor preparation failure. There are different techniques, classical manual technique, stripping, peeling from the trabecular meshwork, the double trephination, scuba technique, pneumatic dissection, hydrodissection, lamellar dissection. I actually use the double trephination technique with Trypan Blue assisted double trephination technique. And I am using for last all my cases, like, and these are my basic instrument. I do not use the heavy costly instrument. These are very basic instrument. I use this Teflon block. The hole is sealed because we need the dry surface sometimes. So hole, if the hole is there, there will be difficulty. So I always put a gum. When the OT people, they used to do it. A stamp is very important, S or F stamp. These are the basic instrument. So when I prepared the tissue, I prepared the tissue after preparation of recipient bed. I inject air into the anterior chamber, whether I do a PI or not PI nowadays. Then keep that air for 5 to 7 minutes. Those 5 to 7 minutes are important for me to prepare donor tissue. This tamponade is also important because it stops bleeding if you do a PI and stops oozing from iris. Sometimes minute bleeding happens even if you do not do PI. And it also clears some edematous cornea due to some extent because you are giving internal tamponade. So a lot of the fluid, you can check it, you can make a pachymetry reading. Yes, it actually reduces and increases your clarity. It also saves my time because this 5 to 7 minutes I take the donor preparation time. But I am telling you, for the beginner, you must prepare the tissue before preparation of the patient because you have only one tissue. Suppose if you have 2 tissues in your hand, then you can prepare in this way. Like I do, my iBank is just 1 floor up and down, OT and iBank. So whenever I get something happens, they give immediately a new tissue. So this is my earlier take that, you see, I first do a 9 millimeter partial trephination with hand only, just light touch. Separate the, discard the DM from the periphery of that. Then I used to leave the DM edge with a McPherson forceps with one edge. Later I changed to a hook technique, you see that it single-handed, you can just peel it like that. It is very fast, and 90% you just peel it, make a hinge, then you make a 3 millimeter trephine in the posterior and the stroma. You lift that cover. Sometimes you will lucky to see this elegant type of just cover, and you just put the lid, flip the cornea back and take 8 millimeter. This is a standard way, and you just take the other redundant part of DM out and put few drops of trypan blue, keep it there for just less than a minute, take it into a injected system. This was my earlier video, but later I have changed this with like a hook. If you can take a chopper, like you can do like this kind of separation can be done very easily. 360 little older tissue, it is very easy, like 60 and above. You can separate it, and then you take just a McPherson. This is a McPherson or suture tire, anything, and you little bit side to side movement, and with an angulation of like 20 to 25 degree angle, you just pull towards you, and gradually you can separate it out. Sometimes during during this peeling, you can see there is a tear is happening one end, and convert this tear into Nike logo sign. So there is a like small circular kind of thing, right? Tick like things happening. Then you can carry forward to complete the your treatment. So sometimes minute radial tear might happen. You stop it there, and then extend that in a round shape it so that the radial shear should not come towards that center. So this was my data earlier published, and you see that the donor failure, preparation failure is much lower. It is almost less than 1%. Now, donor preparation failure, only overall tissue exchange was 21 eyes overall. 7 tissues damaged during unscrolling and 14 tissue damage during DMAC graft preparation. So it is 1.4% almost. So 1.4% in my hand. So I have skipping this. We have changed the concept of donor PD, that is we take from the peripheral. This will answer actually one of the question that how do you define that nasal and temporal cornea or superior inferior cornea. Here during the harvesting, when the technicians are harvesting the sclerocorneal pattern, they put a 2 mark with the scalpel blade at 12 o'clock position in the sclera after doing the conjunctival dissection. They put 2 scratch marks, and my thing is to stain that with a trypan blue. Then I know this is the superior area. Then right eye, left eye, then you can, that way you can do. That superior, we have seen that superior cornea has the highest number of endothelial cells. So if you compare these two graft, one is eccentric and one is totally centric, then this year we have presented our paper, 5 years results of DMAC PD in American Academy cornea free paper session. So if you see these two figures almost same, but the cell count, if you see that one eye, it is after 1 year it is just 955, and after just 1.5 years it is 2457. So this is important because sometimes we see in PK that you have done a nice job, next day you see that your cell count is much less than the other patients are going good. We have experience, there are concept of mature cell, immature cell of the endothelium, all this thing has now recently coming out. We have also changed the situation that during COVID time we have used one cornea. So without making hole, we are doing this. And nowadays, again, the tissue are plenty, we are not doing this. So we have also that without making hole, you can do this like you just make a small bubble there and air bubble and you do S mark here. You dry it X mark. So your endothelium is your posterior stroma, I mean stromal part is intact. You can use that stroma for DALC or other surgeries. So we have used during this our this is also we have done Trypan Blue assisted, so I'll make it little fast. Trypan Blue assisted, it is a kind of PDEC. You see that I am injecting Trypan Blue in the posterior stoma, in between posterior stoma and the DM. So gradually you see that it is going like this. So it is almost 8 millimeter or more. It is just in the interface only. Now you put a punch, make a nick. So DM is separate. I have used this technique, but these are time consuming and it is actually you are saving the stroma of the patient. So you can use it for further anterior lamellar keratoplasty. So we have also used pseudophakic donor during DMEC because this is the tissue. If you see that this is pseudophakic with a count of 2,800, why not I will be using the tissue? Donor age is 67. So this is after phaco. So you see that there are mark. So donor preparation is like you have to make it such a way, and if you use Trypan Blue assisted, you can avoid actually those area which are strain if you do the stain yourself and select the best site of you. So that is one of the reason we go peripherally. And if you do a lab practice, wet lab practice for 10 or 15 tissue, I think it will not be an issue for anybody to have a very good donor preparation. Next, I'll be talking on the basic steps. See, patient preparation is almost same, except that nowadays my time is much shorter. It is 15 to 25 minutes if I do a triple. I do a lot of topical nowadays because patient asking for it, and I say why not, if I can do a cataract, so why not. So almost 60-70% are topical. There is no problem of doing topical. DSEC and DMEC, there are a little differences, like case selection in DMEC is very crucial. As I said, anterior chamber anatomy, round and normal pupil. Donor preparation only manual. Main incision is much less. Recipient preparation is almost same, except that the DM rexis will be like, it is little larger than the donor, 8.5 for 8 millimeter graft. So routinely I do 8.5. And you should keep the anterior chamber little bit shallower. Donor transfer in DSEC is easier. Many techniques are available. DMEC it is difficult, mainly by injector technique. Unfolding easy with BSS and air. But DMEC, this is again the second hurdle. Mostly no touch technique, so you should have some asymmetrical mark to identify which side is DM, which side is endothelium. Donor centration DSEC is very easy. DMAC I sometimes find is difficult in some of the cases, especially with sulcus fixation IOL, SF IOL, deep anterior chamber, high myopia, tube, shunt, etc. So donor centration is difficult. I always says do not be over enthusiastic to make it center because it kills more cell. If you are moderately central, leave it there and the patient will be fine. Ear injection is easy in DSEC, but again a difficult task because you have to go right at the center and very slowly you have to use always 1 mm syringe and just air fill, not over tight. Just you have air fill with a little collar of fluid must be there in the anterior chamber, and supine position for 1 to 2 hours is important for DMAC. The 10-minute concepts I do not do in any cases. I just do the give air, take the patient out of OR because I have another case waiting. So with the bed, patient is lying another corner, and after 1 hour, 2 hours or 45 minutes depending upon the type of patients, I take the patient and see under slit lamp and then decide. So I'll come to it later on. So any case of like this is a case of pseudophakic bullous keratopathy with lot of loose epithelium must be peeled first. This is 8.5 millimeter marking is important. Then side port incision, always just I use normal blade like 15-degree blade, but it should be smaller. I initially used to give corneal incision, but later on a little bit larger. Later on I have switched to post-limbal after bit of scleral because our corneal size is little smaller and you have no stitch, and donor manipulation is easier because your internal incision is much towards limbus and astigmatism is also lesser. So DM scoring same as DSEC, but you have several options. Like if you are doing a combined procedure, you can do under red glow. If the visibility is poor, so you do under Hilon and trypan blue. AR assisted DMAC is very important with SFIL, SEIL, post VR surgery, etc., where we do not use any viscoelastic device into the anterior chamber. Viscoelastic, it is easy and quicker. And always check after, even if you do viscoelastic assisted, so you inject air to check any remnants of DM is there or not, because those are the causes of DM detachment. If certain area is not cleared properly, there will be chances of DM detachment in that area. Then inferior PI, as I was saying that it was mandatory early, in early cases I used to do all cases like with a manual or with a retractor, always check. Immediately I put the air. But about 4 years back, this thing happened to me after doing bleeding from PI. So you see that I did with the retractor, and the blood is trickled to come, and you see that blood is coming, and this blood actually had caused a lot of problem. And you know that this patient actually taught me, I had actually this patient after putting the graft, patient had black ball hyphema on day 2, and then I had to remove that black ball hyphema on day 5 with the graft, survive only for 5 months. So from that day I realized that I will not do any PI if I get a chance. So in this case it is a very beautiful pseudophakia, and you see that I didn't do any PI. So this is a perfect example of without PI. This is about 4 years back. So I dilate the pupil in between the surgery, after putting the graft. Sometimes I inject little bit of adrenaline in the subconjunctival space, ask the patient, the floor assistant to put 1 drop of atropine. So people usually get dilated 6-7 millimeter. This is after graft fixation. Then donor transfer and insertion technique. There are many techniques are there. Again, lot of techniques, lot of things are available. Some of them have commercial value, and people are using mostly Jones tube, goiter, and many of them are using still IOL Curtis. I am using the IOL Curtis, and it is plastic. There is a doubt about plastic or IOL. There are a lot of papers are there. Concept of endo in, endo out, pull through technique, DMAC, endoglide, all are there. But ultimately, what I feel that if you do in the same case again and again, and if your manipulation is less, your principle if remains same, the result will be the same. Consider the cost and time factor also. When you learn a new technique, this is a very small number of cases you will be doing at the end of the year. And then if you try this method, that method, probably you will not be perfect in any method. My suggestion is whichever method is the best suitable in your hand, which is least costly, which is least time consuming, use that and master it. Ultimate goal is ease of unfolding and less cell loss. The more you tap, the more you range fluid inside the enter, there will be more endothelial cell loss. So this is my typical injector. Anybody can make it. I have shown many, I have made it. So this is regular your saline tube, and this is butterfly Curtis. You can just break it easily. This is AI40 sensor multipiece, and you can just, this is very watertight. This is easily fitted with a 2cc syringe. I am very much obsessed with the syringe. I always use 2cc syringe, and I check it is usually attacked, and it comes very easily. It comes very easily, and without just sucking movement, it will take the thing inside the. Before donor transfer, thorough cleaning is important. This is always important if you are using Hilon during surgery and Hilon during using. Sometimes people is small and you are not very confident that Hilon is there. In not go behind the IOL and clean all the Hilon. And also clean all the blood clots, fibrin thread, everything. From the, sometimes you see long thread along the angle. You take the small air bubble, you just take it out. Otherwise, all those will create a problem while you inject. So everything must be clear. It is moderately filled anterior chamber. Now it is ready for your injector system. See that this is a beautiful illustration by Peter Veldman. These are the description given. You can go to the website and see. This is inside the eyeball. So when they put the thing, there are different pattern the DMAC scroll take, and then you act accordingly. So beautiful video in by Uday Devgan also, the cataract coach. You will see all the methods are there. But mind that these are light colored iris. So it may not be possible to see this kind of picture in dark iris. Rather, what I follow, I teach the DMAC in a little differently from outside and try to see what is the pattern of that different type of scroll. You can see different type of scroll. I have given that. Sometimes you may not get a scroll at all. I call it flat DM. Sometimes little bit half scroll, not so tight, little loose. So there are many papers, many classification system. They measured it, what is the width of the scroll, etc., etc. But I always check this even now, and I try to pull the tube in such a way that I try to see the S mark within the Curtis. You see that? So if I see the Curtis, then I go accordingly. That so you always take the tissue in beveled up position. So here I go either bevel entry bevel down always, then I take the tissue out. I know that I am in a right position, then just I use the two hand technique, one hand it iris spatula, another is cannula. I use the fluid in the see I am not using the any suture in the main port, but it is not wise to do that, because sometimes for the beginner it is always better to put a suture. Normally I do not put any suture, so this movement is so conversant in my hand. It is always with the cannula only, I just tap and it opens very nicely. So you can see the S is right. So if the bevel S is right on side position, I go right lateral or left lateral position, I inject it like that, and again I tap, and the main thing is that the V or the shape, it should open up. So you have to check, and then you have to pin one end and then gradually move it, tap it, and then gradually you have to egress the fluid from one of the port, either main port or side port. But if you do from the main port, it has to be very, very slow. So again, you see that it is all right. Again, this is a very important, check the air. So if you see that their air is obstructing actually, so before doing anything, remove that air. So air in the injected system is sometimes is dangerous. The whole graft may come out. So release fluid while injecting. So see that I am injecting and I felt that I was tight. So I was releasing fluid from my left side port and then gradually withdraw it. You always guard the main port. Again, you just move the tissue to one side and gradually open it. If you are sure you're open up in the, like it is a biceps, or we call it like the endothelial side should be down, so your biceps up. So that is the question that you have to see. Then this is a description of perfect scroll. Unfolding may be done. You see that the V is towards looking up. So unfolding is just slow releasing of fluid, not any tapping. You said both the sides I am releasing fluid and the graft is opening automatically, very slowly. I am releasing, I am not injecting anything. One hand is like iris spatula, one hand is cannula. So when it is open fully, you just go at the center and inject air. So this is again, if you are seeing that, again, this is again, you see the scroll pattern. People try to make this scroll. It takes sometimes, depending upon the tissue, you have that kind of scroll. It is again easier to unfold it, because you just fix at the center, and again with the release of fluid from the side ports, two of the side port, one from this side, right side, one from the left side, you just remove it. Remove little bit of fluid from the anterior chamber and make little tap to make that tissue center. And when you see that it is perfectly centered, again you do right at the center of the pupil, you inject slowly the air bubble. So this is the air, little bit of fluid cuff I was talking about. That fluid cuff should be like this. So when you take the patient outside and flat lying for 1 hour, this fluid actually will be gone because the aqueous is forming. So, and you will see that your pressure and the pupil is also dilated. I want dilated pupil here. So it is doing fine. So this is again a difficult thing if you see that the S is reverse here. While because the color of the iris is little lighter, here you can see that it is. So you have to just move the graft in such a way and you have to flip the graft. You see that nice flipping is happening. So you flip the graft in such a way that your fluid will be injecting at the iris plane. So graft is open and you can see that S is now in a right orientation. Again you see here again that lighter color iris you can see better. So when it open it pin the one end and gradually other end tap it again little bit towards the eye, operate from superior and head end. So my intention is to take the tissue towards 6 o'clock position. So if you are operating from temporal side, your intention should be take the tissue on the nasal side. So your movement, sudden expulsion of all that, those can be prevented. This again, after fully opening, you realize that your graft is reverse. Then now you have to again just reverse it. Sometimes it happens, and when it is reversed, again follow the same principle. Just fix at the middle, then gradually release the fluid, open the graft. Is again the graft is reverse. So just little bit of fluid and movement towards 6 o'clock position from my position, and you see that S is normal. So again you fix to the point and fix the graft, then gradually fix the graft at the middle. When you see that the orientation is correct, fix the graft first with the left hand with any instrument, either a cannula or an iris repositor. This is again a video. This is tele actually. I was operating here and the video was showing to other part of the world. And you see that S is reverse and everyone was saying, no, 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 it is right position. I was thinking that S is reverse. Then I take the out after putting the air. Sometimes you have to be, even it is, then same thing. You have to push more fluid. This is like origami shape. And you see that now S is normal, taking the normal shape. It takes little longer, but mind that this type of maneuver actually kills more cell. So you might be feeling good that your surgery ultimately went well, but at the end of the your long-term follow-up, you see that after 5 years the graft is not doing fine. So these we have seen in our series that long, prolonged unfolding time actually kills many cells. This is, you see that this is a 17 years old tissue. So much tight scroll. That is my lowest stage I have used it. So you see that, so I inject it's like, unlike I inject it little in a full force, then it opens little, it takes almost long time, almost say around 8-10 minutes to open this graft. So ultimately you are using the very young tissue, but every tap kills is killing the cells. So you are ultimately losing the tissue. So these are not a good thing that you are using a young tissue and done a DMEC. So that's why 55 to 75 is the ideal age. If you have 50, that is not also, but tighter skull have a more cell loss at the end of 4 or 5 years. This is sometimes unfolding is fun, like this is a case of flat DM. You see that, so in case of flat DM, the chances is 50-50. So you go this and you inject, it's open. So chances are 50-50. So you just see whether it is right or wrong position. Sometimes we use light pipe to see. Sometimes you can see easily against the that silver, I mean stainless steel thing, and it is normal. So it is can be done easier. So these are all unfolding technique. The more you do, the more you will learn. But every case is different, I am telling. Except that Fuchs cases, all Fuchs cases, mostly they do BFs similar level. But every graft doing different. 55 years, 65 years, it may seem that 65 years is a better. Probably no, not always. So this is my routine. I keep the patient in the recovery room for 1 to 2 hours, then take the patient in the slit lamp in sitting posture. If I see this kind of fluid level, I am happy. I send the patient to the ward. If I do not see like this, there is no fluid, sometimes it happens, so I barb the fluid little bit with the help of a McPherson forceps or 30 gauge needle, and immediately you see a fluid level. And if you see this kind of fluid level, your job is done. After 4 to 6 hours, we discharge the patient and we check the patient on day 2 or day 3, not on the day 1. And this is the overall surgery, and immediately we give steroid drop. We see the patient on day 2, day 3, on day 7. Then by day 14 to day 20, we cleared the patient for all activities and everything. Now I'll be touching little bit about complication. So complications in DMEC, there are a lot of complication. Unless you have complication, you cannot learn a subject. Even now I have had always complication, because it is 90% time it will listen to it, but 10% time the graft will not listen to you. This is my list of complication I have published in IGO over last 4 or 5 years back. So initially the failure rate higher, but as you learn, the failure and the graft survivable is much higher. Even now the results are coming 10-year survival, and they are very encouraging result. Up to 90 to 94% graft survive after 10 years. Though the endothelial cell loss, DSEC or DMEC almost similar, but visual quality is always better in DMEC. So as I said, the graft damage happens during preparation. It may have a multiple radial tear. This is typically happens in diabetic donor. So you start from one end and again it will tear, radial tear. You start from other side, again it will tear. So never, you do not think this tissue is gone. This tissue is still viable. So you can use this tissue for your DAL cases. Or if you have in a like 7.5 millimeter zone, the endothelium is good, you can use even for DSEC also. So diabetic donor, as I said, is a 5-fold increase in risk of donor tissue preparation failure. Rescue, you can have always rescue in different ways. So you see that this has happened. That was actually inadvertent touch from one of the assistant actually. That type of, but the graft is like this. it is 3/4 graft, and you can use that graft. People are using hemi DMEC, so why not 3/4 DMEC? So this patient still doing fine. That bleeding from PI side, as always said, that even stopping anticoagulant sometimes may not do good. So you see that blood you always keep here. That what I was telling, that this is the expulsion of DMEC graft while unfolding. After putting suture, even that it may come out from the same port. That time it was in my learning first 10, 15 cases. So from the main port, you should not inject fluid so that it will come out. So also that's why suture important, but suture still cannot prevent the graft to be come out. So DMEC graft may go behind the, this is my fourth DMEC. I didn't know what is the scenario in case of post VR. So it went behind the pupil actually. So it sucks like a negative kind of pressure. Then I completed the procedure. The graft survived well for 6 years. Then it failed. So this happened in 2 of my patient in SFIL with vitrectomized eye. So very careful of tapping them. Keep the pupil minimum size, I mean smallest pupil. Do a small PI, inferior PI is important in this. Not let the pupil little bit dilated, so graft may go behind the iris or may go in the posterior segment also. Then air-induced pupillary block actually not happen nowadays, not happen. In early 1 or 2 cases, I didn't know. Sometimes actually PI may get blocked with the blood clot, or you may do excessive air or gas fill, whatever. But with that examination under slit lamp is very important for 1 to 2 hours, and check the fluid level. If the fluid is above the PI or above the lower margin of pupillary border, if you do not do a PI and your pupil is mid dilated, it should be above the lower margin of pupil. Then there will not be any pupillary block. Then graft detachment, this is almost an happening. The incidence is 7 to 48% in different series. In our series, it is 9.8%. There are many risk factors already I have been discussed in many. And one of the important improper DM is residual viscoelastic. And then SFIOL, SCIOL, tube shunt, post PKI, post VR surgery, multiple graft. Even the people has said, studied that preloaded DMEC graft has a higher graft detachment there and rebubbling rate, because there is a changes in constitution dynamics in the fluid. People have studied it more with organ, I mean that UK people are used that they keep the tissue in a for 30 days, and there is a coating formation of the it makes the graft little bit slippery. So that actually cause a little more graft detachment. I have used that. That is definitely little slippery tissue than the. I have used a live surgery in Sicily 2 years back, and there I did a actually live demonstration of live surgery on DMEC. I felt that I was given that tissue and I felt that it is slippery. So that studies, there are a lot of studies are there. So detachment can be any shape like total detachment, partial if it is less than one third. You can observe this patient closely. You do not have to go for rebubbling. But if again it is the central detachment less than one third, then again you may not do the rebubbling because the periphery is attached always, and you just wait and observe. By 2-3 weeks it is automatically absorbed. I mean attached. And free floating graft, if the stamp is still voluble, try to reorient it, then air injection. Small, as I said, that if the graft detachment is more than one third, it always require rebubbling and subsequent repositioning. I will not say, but rebubbling is required because it is always positioning. And again, you have to do, if with air, or maybe you can use second time, third time, then you can use C3F8 SF6. And some people do rebubbling it as a OPD procedure, but our system does not allow that. I always take the patient to OR and keep the patient in the same cycle, rebubbling. Then we see the patient on the slit lamp, keep the patient for 4 to 6 hours, then discharge the patient. And it can be done in topical or local, because sometimes it may be painful for the patient depending upon the patient status. So this is day 3, and you see that this is day 14 without doing anything. So this graft detached area is attached. I have not done anything. So by 10, 11, 12 or 14 days it may be attached. Steroid-induced glaucoma, as you know, as with any other transplant, you see that this is a good paper published by Francis Price, and this year Kerakon he presented this also, that if you use prednisolone, the chances is 22% steroid-induced glaucoma. FML it is 11%, and loteprednol it is 8%. So if you want to use, this is a very nice study. So we go with prednisolone or dexamethasone initially, and then we, by 6 months time, we tapered to FML or loteprednol. So this is a night study. Everyone should be, because a lot of fellows, and this is important for any kind of transplant surgery. And you know the secondary glaucoma, steroid induced or for other reason, is the most important known risk factor for lead graft failure. You must give an additional thought of secondary glaucoma in any keratoplasty procedure. The graft interface infection, though the incidence is in the Western world is higher, and there were different, mostly with pre-cut, preloaded tissue, and also I know that it is in one of the premier institute, they have higher interface infection because they are using preloaded tissue. So basically repeated cold thaw cycle and taking the patient in IVANC setup probably is the root cause of all. I have 2 patients recently. This is one in recently I had another I have shown in. So this patient is like Candida. This is one in 1150, the 2 in 1600. Recently means about 4-5 months back I had. And you see that this patient is lucky enough, without removing the graft, this patient actually survived, and after 3 years he has beautiful graft, and he survived COVID also, and he's doing fine. And his endothelial cell count, after a lot of this twice VR intervention and intracameral intervention, still the endothelial cell count does good. Rejection, Here it is maybe symptomatic, maybe silent rejection. The incidence may be 0.7 to 5%. In our series, it is 2.99%. Commonest cause is discontinuation of steroid drops. Anecdotal report of COVID-19 vaccination or other vaccination is there, and rejection episode. And you have to 1 hourly dose steroid drops. Maybe supplement with, we do not give actually methylprednisolone in this patient. Perivalvar or subtenon triamcinolone is doing good. Perivalvar always preferable because there is least chance of IOP rise. Usually, most of the cases, if the patient presents early, they revert back. So you see that this is a beautiful how the graft has been going, and rejection after 14 months. You see the even the KPs etc. But typical those line, Kodados line, all are not visible. Sometimes the patient presents with silent. This is like a patient in 2019 I did. Specular was good. But then she came in 2021 after COVID with lot of small, you see that KPs you can easily see. This is without any symptoms. She came for 1 year drop during COVID period. Then she came after 2 years, 2.5 almost. And I saw this. I said that any symptoms, she said, and she was perfectly 6/6 vision. And I treated her with steroid. And after treatment, she was absolutely fine. This is the other eye is having Fuchs. The patient, you see that patient didn't have any problem and no cell loss happens. This was done in 2019. You see the 2600 cell count, and this is also 2696 or 2700 after treatment. So silent rejection episode may happen without any symptoms, and you just detect it. And in our series, mostly I think we have seen, almost 12 cases, just random KPs, but without any cellular other reactions. And we treated them with a little bit step up of steroid, and those KPs gone after 3-4 weeks. Graft failure, PGF. So when we define PGF, we wait for 2 months to declare it PGF. And nowadays it is almost rare, except that if you are excessive surgical manipulation, you are desperate of doing it. Otherwise, there should not be any PGF, or you are doing without giving any stamp. Reverse unfolding happened, and then it might happen. Secondary graft failure, it is 4.8% in our series in 5 years, and mostly related to repeated rebubbling like 3-4 times. Not very the patients are not very cooperative. Glaucoma and prior glaucoma surgery, they would have a higher secondary graft failure. Complex anterior chamber as in eye syndrome. And after rejection episode, few of them actually after COVID, they could not come actually. Rejection had happened, steroid not given, steroid not buying, and they come with failure actually. And we could make that KPs are there and probably due to secondary graft failure. So in summary, in India, we need to do a lot of EKs in any form because cataract surgical rate is now increased 6,000 per million per year. Last year, we had done about 9 million cataract surgery. That means every year, India, if we take 0.01%, 9,000 new EK patient. We have Fuchs dystrophy. Surgical and visual outcomes of DMEC, like cataract surgery outcome. As a beginner surgeon, we need to start this wonderful surgery. And I can take up my question. So there are few questions how to prepare a graft smoothly. Already I described. Can we identify side of the cornea just on the basis of looking it? No, you cannot. You have to mark it. Like how to identify if the side is nasal or temporal. So we have mark it, then you have to point it which side is nasal, right, left eye, you have to, during retrieval you have to mark it. Indication of, contraindication of DMEC, when to prefer it over DSEC. Always we prefer DMEC, but when you are feeling that your DMEC is difficult, visualization is poor, even now I do DSEC because I know that I will be losing one precious tissue. Any specific tips for DMEC in pediatric patient? Actually none, but you have to careful for about their lens status, tenderitis, shallow anterior chamber. There is a low scleral rigidity. So there are only fewer indications are there in pediatric patient, only in shade. Early shade you can do it, but late shade I will not recommend because ultimately that graft will be failing because I have a one eye DMEC, another eye DSEC eye is going good, DMEC failed. How different pre-strip tissue, freshly stripped? Freshly tissues are always good. As I said that because of even if you're using Optisol or this, the external component probably stay with the tissue for in the injector system for a longer, which may not be suitable. So people have many studies are there, so more detachment is there. DMEC in private practice, how to approach when not confident of donor stripping. I mean, you should have a good number when to start DMEC. Unless you have a first you know the rescue, then you should approach the rescue. If you are doing a good number of dissect tissue, dissect, like I always say, if your number is 50, and Pranita has a nice study, she mentioned she overall all India basis, 25 are beginner surgeon, 25% of them are doing DMEC. That means if you have a 50 dissect in number, and it has been published in IGO, very beautiful paper, question answering form, and so you have at that means you are doing 15 in a year, that means one in a month. So very difficult to go forward unless you have a good number like 3 or 4, 50 DMEC, that means you should have at least 100 dissect in your kitty. Then you can go very bravely in your private practice because hospital setting lot of umbrellas are there, big umbrella protection, your guides and your colleagues are there, they always guide you. Individual practitioner, these are little bit hindrance. But you have a spare tissue, always, why not? You should have. You should try it. How much younger the donor can be? I think 50 is the best, 50 to 75. You can use earlier, but as I said, it will actually kills more cell. You may be feeling that I can do 17 years tissue, but ultimately your graft will not be survive for 17 years. So that is all. Thank you very much.
Thank you so much, sir. That was I would say, I think it would help all our readers um, really well because I think you covered each and every aspect of DMEC and your idea of taking questions before the session was really worked well. And we got some questions subsequently, but I couldn't send you. So I'll send those questions. One was about the DMEC triple. When you're planning DMEC triple, how do you take keratometry? Whether you debride the epithelium, then take a keratometry, or you just do like that?
Just do like that. So in advanced cases, we take from the other eye actually. Even if you debride, your corneal thickness is thick. Sometimes we have used the contact lens technique, and we always tell the patient that our biometry reading will not be perfect. So you rather in those cases you go towards more of myopic side. The patient will be happier at least from hyperopic side. If he or she become myopic, at least near vision should be good.
And similar to that, there is a question by Dr. Ankita, whether to go for DMEC triple or planned stage procedure is better.
Stage procedure, if the cornea permits, that means early Fuchs
First, then DMAC.
or moderate Fuchs, if the visualization is good. Cataract is denser. So you can go with the cataract first. The problem is today I have done one such case. The problem of not that. I always plan combined surgery, but the some protocol of CGHS or other EA, they do not give the whole compensation. So if you do two surgeries, you will be given whatever their rate, you will be given one cataract surgery, and after 10 days, 15 days, you do DMAC, you get whatever DSEC or DMAC rate, you will get both the rate. If you do combined, the rate will be 50%. So that way we have to be done, we have to be do patient, we explain this patient, we cannot either you do it in cash or we have to, if you stick to your whatever ECHS or whatever protocol, I have to go because institute cannot loss over it. Otherwise, stage, I think stage is not required. Indian patients are not that type of patients. So if the patient is above 40 in the presbyopic age group, so combine it. Patient will be happy rather than two surgeries. Again, after some times you do DMAC, then the problem is there. If you do cataract and wait, like FECD, a lot of time we have to give guarded prognosis. We say maybe you will be like requiring a DMAC or DSEC procedure later on if they're present with advanced cataract. You know the
Thank you
endothelial cell
so much,
loss will
sir.
be higher.
Yes, I think that perfectly answered the question. And we have another 11, 12 question in our webcast portal. That, sir, I'll share you in WhatsApp because I think
Yeah.
we're already reaching 9. Now I'll go back to my expert panels, Satyamurthy sir and Geeta ma'am. What's your take and any questions or any suggestion you would like to make here?
Yeah, thank you, Dr. Praful. I mean, what we can say, sir has covered almost every, why almost? He has covered every aspect of DMAC surgery. It was like going through a textbook. Excellent. And in fact, more than contributing to the thing, I have learned a lot from his talk. And with such experience and the way he can guide and the way very systematically he took everything, that was fantastic. Only one thing I would like to ask sir is, it's better to have, is it better to have an optical tissue, spare optical tissue always along with this?
This
And
is
of course, I
for the
mean, yeah,
beginner, it is very much. You will get more confident if you have a spare tissue in an
spare
hand.
tissue.
You call two patients, you may
Yes, sir.
respond one case, but if you will get always confidence that
Yeah.
if you have one tissue, then you lose the confidence, especially if you are working alone. If
Correct. That's
nobody
right, sir. Very true. Very true. Nice, sir.
Thank you, sir.
So,
Mhm.
yeah.
Okay. Thank you, sir. This is a masterclass in DMAC, undoubtedly. And I hope it is available on YouTube, Praful, for
Yes, ma'am. In our
yes,
YouTube channel, it will be there.
yes.
We
So
have
we can
previous
share
two
it.
videos from sir also
Yes,
posted there.
yes. Sir, I have just one question for you. So, we do have places, particularly many smaller eye banks, where they do not have the eye bank specular, but to estimate the endothelial cell count. So, what would be the guide for them? Because I think DSEC can still be done based on the clinical evaluation of the tissue. But what about DMEC? I think that's a
very
important
difficult
question.
now.
Yeah.
Any eye bank by government protocol, I donation center or I collect retrieval center is different. But if you stamp as an eye bank, that means you should have a specular.
Yeah, so the most eye banks have clinical specular, sir. But
Clinical specular
the eye bank
में
specular they
तो
do not have, sir.
मुश्किल है.
Yes, बहुत
It
मुश्किल है,
is very
correct. Yeah.
difficult to do
Yeah.
because the eye bank specular is required. Suppose if you are supplying some tissue, this is once in a lifetime you are doing such a kind of operation.
Absolutely, sir.
So you are taking a one-eyed patient, Fuchs dystrophy, or one-eyed patient, PBK. and you will be doing, you should be using the best possible tissue in your hand.
Absolutely.
So unless you have
Absolutely.
a data of that tissue, how
Yeah.
can you use that? The
Absolutely.
patient is
Yes.
expecting a lot, the doctor is, and
Yes.
you are doing a beautiful surgery, and ultimately the outcome is poor after 1 year, the graft
Yeah.
gone. So
Yes.
this is, I mean, not to be done. I will
Not
not
to be done.
advise that,
Yes. Yes,
because
particularly big.
after
Yeah.
so many
Yes.
things,
Yeah.
clinical and this thing is so much different. Even in
Yes.
clinical practice,
Mm.
if you see, that's why many people misses the Fuchs dystrophy.
Yes.
Many people,
Yeah.
many common comprehensive ophthalmologists, they see only pupillary region, the
Yes.
cataract.
Yes.
They do not
Yes.
see
Absolutely.
endothelium.
Absolutely,
So
sir.
these
Absolutely.
are, I mean,
Mm.
not to be encouraged. I mean,
Yeah.
it is
Yes. 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 Because
surgeon,
particularly,
as a surgeon, your goal is to give best tissue, and you are the best surgeon, so you have to best result.
yes, absolutely. Yeah, because particularly in DMEC, the donor age is also older. You're taking above 55-year-old donors. So
Yeah,
you
yeah.
really
So your
absolutely need
tissue
to know
count,
the
and you see
endothelial
that
count.
this
Yeah.
is how you'll be publishing. We have in the manuscript phase
Yeah.
that surprisingly in Bengal, the donor tissue count is also higher.
That's great, sir.
That is surprising. We do not know. We try to get the answer, but we see a lot of Fuchs dystrophy
Yeah.
also. So that is also two extreme things. But as I have learned over a period of almost done like 3,500 EK, DSEC and DMEC, more than 3,600. So I have learned a lot about endothelium. You know, actually the tissue will save you, and it will give you courage to go forward. Unless you do certain past few cases like with a bad quality tissue and results, and you'll be totally shattered. So you will not
Absolutely.
go forward. That why I'll be
Yeah.
doing cataract is good.
Yeah.
Why I'll be, and patient will not be
Yeah.
unhappy. So
Yes.
these are very important things.
Yes. Thank you, sir. Thank you so much for the great talk, sir.
Ahuja sir, any
Fantastic.
comment?
Thank you, Dr. Praful, for this opportunity. I would like to begin by congratulating Dr. Basak for such a wonderful presentation and for sharing his inspiring journey in DMEC. I'm still in the early phase of my DMEC experience with around 50 cases, so my comments come purely from learner's perspective rather than an expert. And what I have strongly felt so far, DMEC becomes extremely rewarding when a few basic principles are strictly respected, starting with the right tissue and the right patient selection, and intraoperatively maintaining a shallow anterior chamber, a smooth and controlled draft injection, almost like we inject an ICL, carefully confirmation of the graft orientation and appropriate airfills are the steps basically that really influence the outcomes, especially in early cases. I believe Dr. Basak had beautifully highlighted all this fundamental today, and all the insights are immensely helpful. Thank you, sir.
Thank you.
So
Very
much,
good.
sir. Any comments from any of the panelists? I think most of them have left. So I think let's conclude here. Thank you so much, Basak sir. Finally, you came to our DOS Super Tuesday program. Thank you so much for that.
Thank you,
And
Praful, for giving me this opportunity
we have
to
a
share my
webcast platform, sir,
experience.
where our delegates they join. So I'll compile the questions and I'll definitely share it with.
Sure, I will answer.
And thank you, Satyamurthy sir, Geeta Bera ma'am,
Yeah.
and sir for joining us today. And I think today is the day of festival all across India. So all our delegates, happy Lodi, happy Makar Sankranti, and all those I think programs that you people are doing. All the
Yeah.
best to all of you, and have a
Yeah.
great day. And thank you so much.
Thank
Thank
you.
you.
Good night.
Thank
Thank
you.
you.
Yeah.
Thank you very much.
Thank you,
Good
Dr.
night.
Praful.
Thank